So this is going to be a poster presentation of the CUA. Title is Diagnosis and Misdiagnosis Given to IC Patients. Introduction. As you know, IC shares symptoms present in many other urological conditions. Other alternative diagnoses given to these patients may delay time to appropriate treatment. Patients may be subjected to unnecessary investigations as a result of alternative diagnoses being given, and patients may receive treatments which are ineffective for their condition. So the objectives of this chart review were mainly to determine the time from onset of symptoms until a diagnosis of IC being made. As well, attempt was made to identify the previous diagnoses given to both male and female IC patients. Materials and methods of the study. It was a retrospective chart review. 32 consecutive patient charts were reviewed. The diagnosis of ICU is made by history, physical examination, negative urine cultures, puff questionnaire, voiding diary, and where appropriate, cystoscopy and or urodynamics. Charts were examined for previous diagnoses given to ICU patients by both primary care physicians and specialists. Many patients had multiple diagnoses. All previous diagnoses were included in the data. The duration of symptoms was taken as the time from initial assessment for complaints for the symptoms of IC to a diagnosis of IC being made. In some cases, the diagnosis had been made prior to the referral to clinic. In other cases, the diagnosis of IC was made at the time of clinic visit. This graph here demonstrates the time from symptom onset to IC diagnosis. There's a difference between men and women. There's 24 women and 8 men in the study group. In women, the mean time from symptom onset to IC diagnosis was just over 6 years, while in men it was longer, 10 years. This graph here details the different diagnoses given to female IC patients. The top two diagnoses in a Canadian setting were urethral stricture and overactive bladder. Those were just over 40% for urethral stricture, and overactive bladder was 40%. Many patients have had a diagnosis of recurrent bacterial cystitis in the past, about 28%. 21% had had a diagnosis of endometriosis, and 8% had a diagnosis of trigonitis. This graph outlines the previous diagnoses given to male IC patients. In this study group, 100% of the patients had at one time had a diagnosis of chronic prostatitis given. Just over 80% had at one time been diagnosed with BPH, and similar to the female population, urethral stricture and overactive bladder were common previous diagnoses. Discussion. So the study showed that IC patients typically have a long delay until time of their diagnosis. Patients were worked up for other conditions and also received treatments for alternative diagnoses. The most common diagnosis given to women was urethral stricture and overactive bladder. The most common diagnoses given to male patients was chronic prostatitis and BPH. So in conclusion, a diagnosis of IC or IC should be considered under differential diagnosis early in patients with refractory chronic